This is batting cleanup here. We got Sal and Hal on healthcare.
Like it.
And Logan. Sal, Hal, and Logan.
Dang it, I wish my name was like Al or something.
That would be
Al.
better.
Something that at least ended in A.
Cow.
If everyone could take your seats. We will have got a couple announcements at the end just about reimbursement and things like that, but and also just want to do another plug for our survey. It's crucial that we hear back. Like I said, if you have suggestions on places to hold the event, days of the week. I know next year is an election year for many of the people in the room, so let us know about that as well. What we can do better, issues maybe we didn't cover. You only have so much time. We didn't even really get into pensions on the last panel, but there's obviously a lot of different issues. So let us know what we can do on that. With that, I want to introduce our healthcare panel. I'm really excited about the panel we have, healthcare and welfare reform. I am obviously not Lindsay Boyd. She's with the Beacon Center. She actually is sick, so I'm pitch hitting for her. But to the left of me, we have Logan Pike, who's one of our state government relations managers and actually co-author of our welfare reform report card, which we'll talk about a little bit. Next to her is Dr. Hal Scherz from Docs4PatietCare. And next to him is Sal Nuzzo. You got it. From the James Madison Institute, one of the best state policy network think tanks in all the country. So with that, why don't we just dive right into it? I guess you can't really have a healthcare panel without at least talking about Obamacare and how it's affecting states. A large portion of that is Medicaid expansion. I know here in Tennessee there's been a big fight that went on. Florida, there's been some fights. Sal, what's kind of the status of Obamacare at the federal level, and then what are you doing at the state level? What can states do?
Well, first and foremost, I think the last thing that we had heard judicially was the King v. Burwell decision. And so most on the left had decided that was the be-all, end-all, and therefore Obamacare was here to stay. What we've seen happen since then is this kind of what I would call the beginning of the death spiral. And that's something that those of us in the conservative realm have been kind of warning those on the left about. We warn that this is kind of a house of cards, and we're starting to see where big providers, big insurers like United Health are effectively saying, look, we can't continue this. And so depending on what happens over the course of the next year to two, we're going to see potentially a pretty big shift in where this goes. Unfortunately, I think I've come to the conclusion that while I would have thought it would have been just a kind of a Machiavellian issue a few years back, I do think it's just an opening for single payer. I think what we're going to see is that the entrenched interests behind Obamacare are going to pretty much say, look, this market will only work now if we have a single payer. And that's what we saw videos of President Obama years before he was elected president talking about this being one step. And so I think folks like Rush Limbaugh and some others that have kind of predicted this are going to be proven right.
Yeah, I think part of that, I mean, the Medicaid expansion portion is a big, that was kind of the way, get more people on government health care.
Yeah.
No matter how good or bad it is, if it fails, who cares? And as you said, we can maybe replace it with single payer.
Yeah, and Florida's experience in this, 2015 can be only described as a crazy year for the Florida legislature. In Florida, we have a super conservative majority on the Florida House side. On the Senate side, there are 40 senators who I think 26 of them are Republican, but we don't call them all conservatives. The Florida Senate decided they had some brilliant idea to thread the needle and put forward an idea for accepting the expansion dollars and promoting what they called, it was FHIX, the Florida Health Insurance Exchange, which they thought and they promoted as a free market alternative to Medicaid expansion, when in reality it was anything but. It was just accepting the federal dollars, promoting too little two little aspects of their new program that would have been vetoed by by DHS anyway when they applied for the waiver, and we would have ended up with traditional welfare. The Florida House was unanimous almost in opposition to this, and that was the big linchpin for beating this back. When the governor of Florida, Rick Scott, saw that there wasn't going to be anything coming down the pike legislatively, he saw that as his opening to say, well, I'm against this anyway, so if you decide to go this route, I'm going to veto it. And at that point, the Florida Senate did what they could only do, which was to throw a temper tantrum that caused us to have 4 special legislative sessions. They put the budget in hostage mode, and they actually had a special session at the same time that they were having committee weeks for the 2016 session. So they were here for 2 reasons. So we have not seen a break, the part-time Florida legislature with the full-time Florida legislature for 2015, and we will see something similar in 2016, but it's far less divisive. It's going to get some lip service and kind of go the route that it should.
Sounds like fun.
Oh,
yeah.
It's a joy.
So, Dr. Scherz, from a physician point of view, what is your organization kind of recommending in terms of moving forward with kind of the Obamacare and kind of what's going on? What's your viewpoint on what's going on?
Well, I am a full-time practicing pediatric urologic surgeon, so we're seeing things from a very different vantage point than policymakers, and we're seeing people who are coming into our offices who can't afford care, who are postponing surgeries, who are doing things very differently than they used to do. So Obamacare has affected everyone. What we've heard in this day of panels is that everything that we're talking about is about money, it's about power, it's about influence, it's about picking winners and losers, and that is the embodiment of Obamacare. It has, the losers are, well, the winners are the hospitals that are aggregating power, and Obamacare has allowed for this to happen by the consolidation of hospitals and ignoring antitrust, which is it's blatantly antitrust what they're doing, and allowing them to buy physician practices to aggregate healthcare under one roof. The winners are the insurance companies that are limiting care. They're making record profits. I've spoken to insurance company executives that are making more money in the last 3 years than they have at any other point that they can recall. Other winners are IT companies that have perpetuated the myth of electronic medical records and penalize physicians who don't acquiesce to using it and fulfilling certain criteria via meaningful use. So there are many winners that the government has picked. The losers, unfortunately, are the patients and the physicians. The physicians who are and have always been the advocates for their patients are big losers, and they're demonized as the cost center when in fact only about 10 to 12% of healthcare costs are coming out of physician costs, direct payments to physicians. The majority of these costs are going to other interests in the healthcare delivery chain that provide zero value to the healthcare experience of patients. You asked, John, what are we recommending? What are some of the directions that we believe that we can make an influence? And talking to people who are in state legislatures, I think that the big win is going to be to try to give patients alternatives to what they've got right now. There is a loophole in Obamacare that allows people to access care with primary care doctors, direct primary care. Some people may have heard of it, many have not. It is a a delivery system where people contract directly with a physician for a very modest amount of money. It's not concierge. Concierge is completely different. It's where you pay a fee to a doctor in addition to the insurance payments that you're currently making and accessing your insurance plan for health care. Concierge medicine is where you have increased access beyond seeing that doctor on your insurance plan. Direct primary care is different. On average, it is about a $50 to $80 monthly payment, less than it costs for a cell phone, and you can get a certain suite of services that you can access, which in many of the practices are between 20 and 25 visits annually. Laboratory, basic laboratory kind of tests that a family doctor can give in their office, an EKG, a stress test, maybe a chest x-ray and an ultrasound, a mammogram for women. And this is, healthcare for less than $1,000 a year. And in 13 states, the direct primary care has been defined as a delivery system and not as an insurance product. And this is what all of y'all can do in your states. You can be advocates to allow patients to be able to get this kind of product because there's a risk involved. If you're a physician and you decided that you wanted to set up a DPC practice, you could get shut down by the state insurance commissioner or by the state legislature if they decide that they're not going to recognize this as a delivery model instead of it. They're going to say it's an insurance product, not a delivery model.
It's a health plan, not a health expenditure.
Correct. And the other things that I think go hand in hand with all of this are certificate of need laws. We heard about this in the presentation at lunch. Certificate of need is really important because it is price fixing, it is restraint of trade against entrepreneurs that would be able to set up lower cost healthcare centers than hospitals, which are the highest center, the highest acuity place to deliver health care.
Yeah. You have anything to add on that?
Couldn't have said it better myself.
The one thing I would love to chime in on certificate of need is that we talk about the federal government as the biggest enemy in all of this. We want to get the government out of healthcare. The federal government repealed the federal mandate on certificates of need in 1986. So we've been operating for almost 30 years with even the federal government sees this as something that stifles competition and is wrong. So when Barack Obama and Rick Scott agree on something, we kind of see it as a win-win.
Yeah.
It's something where most states have kind of begun the process. What they're running up to, and the doctor was real poignant in this, is they're running up against the hospital lobby. There is one interest in this that for whom the status quo is the best option. It's not as good for patients. It's not as good for primary care physicians. It's not as good for parents. It's not good for anyone. And in Florida, we've got 11 CONs on the books, 11 categories for CONs. And so we're working in our capacity as a think tank to try and begin the process of getting movement there.
I think on the same point, we always hear, the federal government's taking more and more control over healthcare, and states have less influence or less able to do less things. I think that's generally, accurate and true, and that's what we're running up against. Certificate of need and direct primary care, I think, are two state-based solutions that either states aren't looking at or they just can't get them in large part due to hospitals. So I think this is something we, as conservatives and free market advocates, we can't just say, I don't support Obamacare, I want to repeal and place it. Well, that's great, but we need to, how can we increase access to care, lower the cost of healthcare.
So I'll chime in on this. So that's precisely the issue. And let me tell some stories, because stories are always what I think
Story time with Hal.
they resonate. So in Oklahoma, anybody from Oklahoma here? Oklahoma has certificate of need, but no certificate of need for surgery centers. For hospitals, yes, but not for surgery centers. So in Oklahoma, there is a surgery center, the Surgery Center of Oklahoma, and it is it's a grand slam win for consumers, and let me tell you why. Because what they have done is they have created a model where they do unit pricing for services. So they give a one price cost out the door for different kinds of operations. So one example for it that they like to use is a knee operation. Everybody has had a person in their family or a friend who probably had some knee surgery. And if you look at the EOB for that at the hospital, it costs in the neighborhood of about $100,000 after all is said and done. They can do it for 1/5 of the price. They can do other surgeries for 1/10 of the price. So they have, instead of creating a center that has made costs go up, which is the argument in the CON world. This is the straw man argument. In the noontime lecture, we heard a little bit about CONs and how they came to be. The reason why they came to be in 1974 is because some people in New York State decided that they wanted to curtail competition. They used indigent care as the pretense. And they said that if they would give these hospitals a monopoly over new building, that they would turn back that money into indigent care. And in every study that has looked at it, it has not proven true. It has not improved indigent care one iota. So instead of the Surgery Center of Oklahoma increasing the costs, it's slashed costs by 80 to 90%. And it's provided better care. People were doing medical tourism to Costa Rica or to India because they couldn't afford the hospital bills here in the United States. Well, they're not doing that anymore. They're taking Southwest Airlines to Oklahoma City, and they're doing medical tourism, staying in a Renaissance hotel and getting their care for 1/10 of the cost that they do in Atlanta or in Nashville or someplace else with a board-certified surgeon. So there are solutions that can happen at the state level to make this possible. And in the direct primary care world, my cohort who works with me on Docs4PatietCare, Lee Gross, the aha moment, the jaw-dropping moment in his presentation is when he shows an EOB for a patient of his that didn't think abdominal pain did not think about coming to him, but instead went to the emergency room. And after they did all the testing and they did the CAT scan and they did all the lab work, the bill came out to slightly less than $20,000. And Lee showed what it would have cost this fella if he would have come to him instead with abdominal pain, where he would have done the identical evaluation. It would have cost $298. So these are
good? Is that good? Yeah.
So that's what you can do at the state level. That's the easy lift. Direct primary care is the easy lift because there is uniform agreement on both sides of the aisle about the utility of this model in terms of access of care, lowering costs, better outcomes. There's no argument here. The heavy lift is the certificate of need because of the hospital lobby.
Do you know off the top of your head which southern states have that direct primary care problem of all the southern states?
Pretty much.
So it's pretty much the southeast kind of direct primary care problem?
It is. Okay. I think Florida just now got this through the state legislature, right?
There's a bill in the 2016 legislature, a number of different things. It was proposed last session, but because of the conflict between the House and the Senate, just about everything kind of went the way of a slow, painful death. It's coming back now, but it has, I do believe, bipartisan co-sponsors.
Oh. So that's even something that's bipartisan in nature?
In the sense of the left and those in favor of big government consistently give in my opinion, sometimes valid criticism of those of us on the conservative side that you're so eager to say what you're against. Tell me what you're for.
Right.
And I stood in legislative testimony in 2015 before the Florida Senate, and they hammered me for a little bit and then said, all right, you're against expanding Medicaid. We get it. Tell me something you are for. And this is one of those things that we can point to and say, you want to know what you're for? You want to know what the market, where you can bring market forces to bear? Right here. Do this. And you will cut costs, you will increase access to care, you will increase patient outcomes long term, because people are far more likely to go to their doctor when they know they've got 25 visits per year, they're paying a monthly subscription fee, which is really what this amounts to. And so that's one of the things where we can take the left's argument and turn it right on them.
Between direct primary care and certificate of need reform, I mean, it's those two solutions are basically doing a lot of the stuff that Obamacare claimed to be doing. Increasing access.
Actual care.
Yeah,
affordable actual care that's better care that people can actually, afford, and those types of things.
Well, not only that, but this is a solution to the Medicaid problem. With regard to Medicaid expansion, which I think everybody in the room would probably agree is a bad idea, if a state decided that they would embrace direct primary care and give every Medicaid recipient a direct primary care doctor, which would cost just $800 to $1,000 per Medicaid recipient. The primary care part of health care encompasses about 60 to 70% of the health care dollar. So if you can take care of that population, you can redirect them into your office instead of them going to the emergency room or or urgent care center with sniffles, which is, again, the highest acuity place to deliver care. And you can keep them healthier so that you're, in the long run, decreasing costs. You literally can shave off, depending on the size of your state, $1 to $2 billion with a B, if you just sit down and do the math of what this would cost. And then if you would throw in certificate of need reform, and you can get the costs out of the hospital and into a lower acuity setting, like a surgery center of Oklahoma, or I have people who are ready to set up a surgery center of Georgia tomorrow. If we can get CON reform, then this would slash state healthcare budgets by a figure that is inconceivable.
Anything to add on that?
I was going to say, Logan, we're kind of leaving you out here. What you got?
We're waiting on a different topic.
Okay.
So that's a good transition, though, actually. So in 2015, Heartland did a report card on welfare reform, which usually goes through Health and Human Services. So I wanted to bring Logan on this panel to talk about that report card a little bit, in large part because a lot of the states that rank badly on welfare reform, and we're mostly talking about temporary assistance for needy families, or the TANF program, and to a lesser degree, food stamps, it happens to be, the southern states happen to rank pretty poorly. So can you just kind of give a brief overview about that report and maybe what southern states are doing bad and what they can do better at?
Sure. So there are over 126 means-tested welfare programs, and we spend $1 trillion a year on them, and we've done nothing to get people out of poverty. So Heartland looked at a program, the TANF program, that's a block grant program, in 1996, was given to the states, and we looked and we didn't say, okay, states aren't doing enough, let's do more, let's spend more money. We said, what are states doing that's not working? So we picked 5 different programs. One of the main ones is work requirements. We know that work is what gets people out of poverty. So if you look at 100 people, average 100 people who are working full-time, 3 of them live in what the federal government considers poverty. And even part-time work, 15 of them live in poverty. So we, in our report card, are encouraging states to implement immediate work requirements. And that there are 12 different programs that can go from actually working to being involved in a vocational training, GED, community service, anything like that. If you're enrolled in some type of job training or you're actively looking for a job, that's considered a work requirement. So that's one thing, and I believe 41 states have immediate work requirements in place. Some give you a little bit of a leeway, so we're encouraging states to make that immediate before you can start receiving benefits. Another program that we look at is a cash diversion program. It's basically a one-time lump sum that's given to recipients without putting them on the entire TANF program. And I use the example of a single mom whose car breaks down on her way to work, and she doesn't really have money to fix her car. Her only option without this is to go on the TANF program that she would be allowed to be on for 5 years. And she really only needs that one sum to kind of help her get back on her feet so she can get back to work, continue to provide for her family. So 33 states have that in place. The third program we look at is time limits and how long you can be on temporary assistance for needy families. And
Some places it's not really temporary.
I stress the word temporary because it's the first letter of the program. So the federal requirement is 60 months. A lot of states have started to up that to 24 months or 36 months. Arizona did 12 last legislative session, with the idea that when you allow people to be on this program for 5 years, you're ingraining habits in them that they have. I don't think it takes 5 years to find a job.
You're basically addicting them to government money. It's kind of like what we're talking about Medicaid. It's
Yes.
Once they're not becoming self-sufficient, they're staying on government dependency.
Yeah. So another program that we look at is service integration, and I think this one should kind of be keen for lawmakers for multiple reasons. Price-wise, there are some state legislators that I've talked to that said our state doesn't even know how much money we spend on welfare programs. And that's because you have all of these programs and all of these different departments, and then you're requiring your welfare recipients to go to one location if they want food stamps, and then if they need Medicaid or they need alcohol and substance abuse, you're making them go clear across town to get that. And if you're asking these people to climb the ladder of opportunity to become self-sufficient, it's going to be really hard for them to do that if some rungs of the ladder are missing. So when you integrate those services and you put them in one department with one single case manager that can work with them, it becomes a lot more easy for them to become self-sufficient. I think I missed one.
Sanctions.
Sanctions basically, you are sanctioning people on TANF if they're not compliant with their work requirements. And we're encouraging states to do full family sanctions, so taking the entire TANF check away from them rather than just the adult portion. So states that are kind of not doing so hot that are in the room, Georgia is at the bottom, I think 44th or 45th.
Yes.
They are working on it, though.
They are actively working on it. Alabama is also 44th or 45th, got an F. Missouri was 50th, and they had a big omnibus bill last session, and so they're going to increase a lot, basically did everything that we told them to do. So a couple others. Tennessee, I think, is around
D or
yeah, 23. North Carolina is pretty good. I think they're in the top 10. South Carolina's
Middle of the pack.
yeah, middle of the pack. West Virginia's middle of the pack. So a lot of different programs that that states can adopt that are actually going to get people out of poverty rather than just spending more money.
It looks like Nathan handed out some of those report cards, so if you have any questions, Logan's keen expert. I know we're working in about a half dozen states on that issue. With that, why don't we just open up the questions from the audience? He's bringing the microphone.
Senator Holmes from Kansas. And my question is about the direct primary care. We have, our hospital association is going to make a real big push in 2016 for Medicaid expansion. And this, of course, they're appealing to the rural part of the state where we have very low density population and very small hospitals. And they're saying Medicaid expansion is the only way those hospitals can survive. And I'm wondering if we could get more information on the direct primary care or get someone who would come and make a presentation in our
Sure.
state.
We would be happy to have somebody talk to your legislative body and go through what's involved. We know people in the Midwest who are direct primary care doctors who we can have come in as well. But the thing about direct primary care that people don't realize is that this is a lifeline for family practice. Family practice is dying on the vine, and part of the reason is because of scope of practice, because nurse practitioners and retail medicine like at CVS, or now Walmart is getting into retail medicine, and this is just another nail in the coffin for the family practice specialty. So people aren't going into family practice graduating from medical school. If instead you had a predictable model where they can succeed financially and have great job satisfaction, the thing about direct primary care that's so appealing is that you have a certain number of patients. Instead of having to see 50 or 60 patients in a day to make ends meet because of all the government regulation. These are people who have opted out of insurance, opted out of government health care, and they're able to actually reduce their overhead because they don't need 6 people or 7 people, which is the MGMA average number of FTEs that a doctor has to have to run a practice. They have 3 people. They have somebody to check people in and take they don't even have to collect money because it's automatic on a monthly debit on their debit card or credit card. They have somebody to check in, and to check out. They need somebody in the back to help put people in rooms, and they need somebody in their business office. So their overhead is slashed. They can make a predictably decent amount of money. And so we talk to young doctors. One of the organizations that we're very much involved in is an organization called the Benjamin Rush Institute, which talks to re-educates young doctors who are unfortunately being brainwashed in medical school by people who are on the wrong side of this issue. And the number one concern for young doctors who are graduating from medical school today is, will there be a hospital job for them? Obamacare is killing private practice. And we talked about single payer, that's the ultimate goal. The second goal is to put private practice of medicine to bed, to kill it. It's
completely centralized.
It's going. And they want all health care to be delivered at the hospital level. That's the ultimate goal. Well, obviously there are enough of us with gray hair who do not want to see that happen, and it's bad for patients. It's bad for everybody. And when we work on a direct primary care model, it's a lifeline to family practice, and it will help to regenerate that specialty, and there'll be more doctors. So it's the answer to the doctor shortage in rural America.
The only thing I would add to that is I would encourage you to get with your state-based think tank. I want to say in Kansas, it's
Kansas Policy Institute.
Kansas Policy Institute. We partnered with our friends in the House to fight back on the Medicaid expansion piece, and you will have a fight on your hands. The federal government, the Department of Health and Human Services, threatened to withhold about $2 billion in low-income pool funding for Florida. At the kind of, we likened it to having a gun at our head, and it was a battle. So I would encourage you to get with your state-based free market think tank. We've got lots of op-eds, materials, they'll have some too, and really partner with them to begin that push.
Questions?
David Byrd, State Representative in Tennessee. You said a while ago the price on the primary health care or the direct primary care, is that per person?
Mm-hmm. So in the Epiphany Healthcare, which is Lee Gross's model outside of Sarasota, he's charging $80 per person and $25 for each child up to 2, and then everybody else in the family is free.
I'm Janice Spelling from Tennessee. Last year we had a battle. Had Lindsay been here, I guess she would have been able to speak to that, with Insure Tennessee. Did you all pay any attention to that? Did you see the devil in the details in the weeds? Because I had the good fortune of being appointed to the committee that heard it first and had to do an up or down vote on it. And
On the Medicaid expansion piece?
yes.
Yeah, how it had worked out was when the feds basically told the governor, look, you're going to lose $1.9 billion in low-income pool funding unless you expand Medicaid, it put the Senate onto this kind of high alert thing. And so they received a proposal from an advocacy organization, which was basically made up of a lot of hospitals, that attempted to put forward a free market solution to Medicaid expansion. And so we had to spend an inordinate amount of time dissecting all of the different elements of that proposal and point out all of the areas in which all that they were going to do was end up with a traditional Medicaid expansion and really, I hate to say this, but John Kasich and Ohio were our best friends, because John Kasich decided they were going to expand Medicaid, and now they're looking at about $2 billion more a year than they projected. And it was roughly $700 million at the time when we were engaged in the fight. So we could say, look, don't believe us, believe Ohio. Look at what they're doing. And so, yes, the devil was in the details on this, because as much as our state chamber of commerce is an ally of JMI in a lot of the things that we do, on this one they went the other way, and so it was kind of us and Americans for Prosperity, the lone voices in the wilderness, taking all the shots from the Senate on it. But yes, the devil is in the details.
And I think it was Americans for Prosperity that came out with the map of what every state's increased Medicaid expansion obligation would be, and in New York and California, that increased obligation was in the realm of about $15 billion extra.
The numbers of people that would sign up in about 24 hours went from 180,000 to 400,000 and was still rising. And 50 to 74% of those people would have been below 100% of the poverty level, which would have made them impossible to. It was supposed to have been a pilot. Well, you can't get rid of them once you put them on.
Right.
It was a disaster looking for a place to happen, in my opinion, after I studied it. But we're concerned that it's going to come back again. There are rumors of that already, and so the information that we can get from other states and whatever to see the disasters that free money, and something that people don't talk about, the $800 billion nationwide that was going to be taken from the codes for the traditional Medicare people, so that now you have underinsured.
Correct.
And the delta from the underinsured and what you get from the newly insured actually was going to be a deficit. So it was just incredible. So all this, I was encouraged by your comment that said that the death spiral has begun. So
Yeah.
hopefully it will wind itself down.
There were two elements of that. Before the United decision or the United kind of news, there was a little publicized fact about all of these health co-ops that were set up to help run a lot of this are all finding they can't operate. And so I want to say it's something like
11 have
11 have
closed,
yeah.
and everyone is running in the red except for one.
So that was the first part. Now you've got United saying, but I come to this point again. I've come around to the decision or to the realization that I think this was all by design.
Okay, the
great.
community organizers that followed
Yep.
around said, well, we don't really like Obamacare either. This is just an innocent step
Yep.
to get us where we want to be.
Yeah.
So we've got to be socialized. We've got to have socialism in America if we're going to prosper.
And I think a lot of states or conservative states are looking at what Arkansas did as kind of the free market way to do it, and I think we've seen a lot of problems with that model, the private option, if you will.
Yeah, in Florida, we're looking at now, we've got the ear of the Florida Senate. So our healthcare reform priorities at JMI are certificate of need reform, direct primary care to kind of enshrine that in policy, looking at scope of practice expansion, and then telemedicine. So we call it like our four pillars of free market healthcare reform. And all of those priorities either have bills that have been filed or are in bill drafting right now for 2016.
And none of them grow government.
And none of them grow government, yes.
And I know Heartland's done some stuff on the Tennessee issue specifically, so get with us. We can definitely help out however we can. I was hoping Lindsay would be here because I knew that was a big issue, so it would have been great. But yeah, any other questions? Isaac? Or him? Yeah. Okay, cool.
Hi, Martin Daniel, representative from Tennessee. I want to thank you for being here and sharing your advice and your wisdom with us. I have a question regarding certificates of need, and I don't like them. Tennessee is solidly Republican. However, we have one of the most restrictive CON laws in the nation. And one of the arguments that we are encountering on our way to reform is this, that the hospitals have to take all comers.
Mm-hmm.
Under federal law, they have to take anyone who walks through the door, payers, non-payers, in between. If we allow surgery centers and imaging centers to go out here and proliferate, they can pick and choose who they service. And that would be not an equal playing field, would not be fair competition. How do we get around that argument?
Well, this is why I think that incorporating CON into a total Medicaid reform package is a winning combination, and we're looking at that in Georgia. And it's heavy lifting. I won't lie, but the DISH funds that we're talking about, the disproportionate share funds, which the hospitals would lose if they don't have those people coming through their doors. If you can make up some of that delta with the money saved by delivery of care in a more efficient way and in a lower acuity setting, and make them, if not whole, you can help put a Band-Aid on some of that bleeding. You can possibly get them to come on board, but there's no incentive for them to stop spending money to oppose any kind of effort to repeal CON. At this point, they'll fight tooth and nail because right now they're empowered by the federal government and by the status quo.
And I think you can point to other states that don't have certificate of need to show that that's not the case. I mean, it's worked. There's plenty of states without certain certificate of need.
I want to say 16 or 17 states have no certificate of need laws at all and are operating quite efficiently, quite effectively, provide care. Their hospitals are not. We look at the CON debate as an element of it stifles innovation. It stifles access to care, and all it is doing is protecting entrenched interests over patient care. And when you frame the argument that way, when the hospitals come out and say this, exactly what you said, I would say if you respond in the wrong way, all you're doing is responding on the terms of their debate. So when we frame the argument as this is about
Patient care.
Patient care and patient outcomes, and making sure that, we sometimes use an analogy at JMI on these types of things, that where it's like Burger King having to ask McDonald's for permission when they want to open a new restaurant or on a location. I mean, it just does not make sense. It doesn't make sense in technology. It doesn't make sense in food service. It doesn't make sense in healthcare.
And it's also an access of care issue as well, because the hospitals or facilities that could be opened in places where there is some opposition because of an existing CON, that disappears when you get rid of the CON laws, and it will expand care to places where right now it's sparse.
Delegate Michael Moffitt from West Virginia. The direct primary care, if we set that up to assign everyone a physician, what happens with the catastrophic issues and the ever-growing pills prescription problem we have? So
there's it depends on, again, if you're setting it up for the purpose of Medicaid solution, they have Medicaid for their catastrophic care. So they've already got a catastrophic care plan. If you're looking at it as an option for patients or for employers to be able to provide a product for their employees, well, that's part of the mandate by Obamacare. You have to have a high deductible wraparound. Unfortunately, the way that the insurance market is going right now, those plans are harder and harder to find. But I think that if the marketplace opens up, insurance companies, they're in the business of making money, and if there are more and more direct primary care recipients who are in need of a wraparound high deductible plan, those will be available, and why wouldn't a 50-year-old couple want to get a high deductible plan that doesn't have maternity benefits, that doesn't have, all of the other bells and whistles that right now are pricing them out of the insurance market?
One of the other problems with the high deductible plans is, so if you have a HSA attached to that high deductible plan,
right,
you can't actually use those HSA dollars to buy a product.
That's right.
Because it's being considered insurance.
Right.
So that's one of the problems, but that's a federal problem.
Exactly.
So.
And I think there's a bill that is being proposed to try and change that. However, it's
that would be a big shift, because then you could have this
Bill Cassidy is introducing a bill in the Senate that
so you can use your HSA,
that's
which
right.
are pre-tax dollars. That's
right.
the big rub there.
This is Mike Thompson from Virginia. 3 things that might be helpful in this discussion. Pennsylvania has not had a CON law since the mid-90s. Legislation was introduced last year to bring it back. The Hospital Association and the doctors testified against bringing it back because they said, we like not having this law. And the poor are taken care of in Pennsylvania. The hospitals are okay. The doors are open every day, as they are in the other 14 states that don't have these CON laws. So most of the arguments against it are really the typical government-type arguments, in that we did it yesterday and we want to do it tomorrow because it's convenient to do it tomorrow the way we did it yesterday. And the fact that the hospital associations are on our side in these states, at least in Pennsylvania,
I'd love to get a copy of that.
they become a huge asset that ought to be in our states testifying. Second thing, Paul Ryan told the SPN group in March, and I understand he said this publicly other places, there's no way the 90-10 split in the part of Medicaid that they're talking about can be sustained. He said it's going to take a couple of years, but that brick wall is there. And he said, you give us a Republican president, Said it's going to become at least 50-50 like the rest of the Medicaid program. Figure out what that does to your state budget when the whole thing becomes 50-50. Third thing, we found out last year that there is a website in Virginia called the Virginia Hospital Information Website. It shows every hospital in the state's profit and loss, net worth, etc. And the hospital association wrings their hands, goes to the press and say, we need Medicaid expansion, we need the CON laws because we're doing so poorly. Well, that's not necessarily the case with the figures that are published from the hospitals themselves. Between 20 and 25% of the hospitals are running in the red. That's true. Year after year, a year ago, year over year, the industry as a whole had a 10.7% profit. We publish a new updated figures Friday or Monday this week that will show on top of that the next year, the last year the figures are available, is an 8.7% profit. In that year, 7 hospitals net have gone from the red to the black. And when you take a look at the hospitals that are running in the red, a whole lot of them have net worths in the tens of millions of dollars. We published these figures, which are the hospital figures, and it killed Medicaid. The Republican caucus went absolutely ape when they saw the numbers. And it's really hurt the hospital association because they are basically brush off their press release from 4 years ago, put a new date on it, and say we're all nuts because the hospitals are doing poorly. Their own numbers show that's not the case.
And a part of that also goes to the immense challenge of the lack of price transparency in the delivery of care. Mm-hmm. And that's something where if we were to consider kind of the 8,000-pound gorilla in all of this, the lack of price transparency has led to exactly the point that you just
And
made.
the hospitals talk about all the charitable care that they give, which is great. And they should, and those that are nonprofit especially, I think you have an obligation to do that. Our Secretary of Health, who was McDonald's Secretary of Health and stayed in the Democrat administration, publicly said about 2 months ago that there's no way of knowing how much charity care is given because each hospital accounts for it differently.
Absolutely.
Some of them account for it at their cost, some of them account for it at what they bill out,
Yep.
et cetera, et cetera. So, the whole number thing that the hospitals throw around, they're really pretty fallacious.
This kills me because the hospitals don't give any charitable care. The doctors give the charitable care. And so when I sit down with people who say this, the hackles on the back of my neck go up. And doctors will continue to give charitable care whether or not there is CON repeal or not. And so this is a specious argument on the part of hospitals. Second of all, you're 100% right. The hospitals have they have fancy bookkeeping where they don't really reveal their true profit. They're all non-for-profit. Most hospitals are non-for-profit. And so they don't distribute profits. But what they do, they've created an entire industry of middle management. At the hospital that I work at, there are probably about 20 to 25 executive vice presidents. And they've got an endowment of $2 billion. And they cry, that they can't open up another clinic, or they can't provide another service that the doctors at the hospital are asking for. So the hospitals are, what they're doing right now, they're aggregating power. In rural hospitals are still hurting. They're going out of business. But in urban America and suburban America, the hospitals are aggregating the healthcare power in their areas, and they're vying for control of the doctors, of the product, and they're making more money now than they ever did before.
The hospitals will tell you, this is such a complicated industry, you don't understand the numbers.
Yeah, right, we don't understand.
You sit with them and you say, all right, hospitals are complicated, obviously more complicated than the family grocery store down the street or the hardware store on the other side of town. But everybody hires accountants to do one thing, get that profit number as low as you legally can, which means the hospital figures that are published are as low as they legally can. And you talk to doctors who are on these boards, they say, yeah, we basically have two sets of books, those that we deal with every day and those that we legally can get that number as low as we can. So it's not complicated. It's the same basic goal. I don't care what your accountant's doing. Get that figure as low as you possibly can.
It's not complicated. Steve Brill wrote a couple of Time magazine pieces and a book about the high cost of health care. It was, I think, the second Time magazine piece was my $190,000 heart surgery. And he exposed his EOBs, how much it cost him for his, $5 aspirin or his, $100 catheter, and it was, unfortunately, the hospitals, it's not expensive giving health care. I can tell you that as a physician. All we're talking about is time and effort. What's expensive is all the regulations and everything else that we have to do to jump through hoops to be able to keep our doors open so that we can deliver care to people. And the hospitals, they're getting paid at a different rate than the physicians are. That's why hospitals are purchasing the services that are being delivered by doctors right now. If a friend of mine has a GI lab, he does colonoscopy, sold his GI lab to the hospital for 7 times earnings, and the hospital. The next day, the name on the door changed from his practice to the hospital's name. The cost of the procedure went up 10 times. So if the cost of the procedure goes up from $200 to $2,000 and the patient has a 20% copay, do the math. And that's an enormous amount of profit on the part of the hospital.
We got time for one question, but I'm sure they'll be around for a little bit, so.
Okay. My name is Isaac Latterell from South Dakota. This question is for Ms. Pike. I was looking at this thing, and I'm sorry if this was a little bit later than we had discussed it previously, but I was getting ready to brag about being the #1 state here for TANF recipient decline and state welfare policies until I noticed that the welfare recipients per employee was 3.6. And when I did the math on that, it came out to basically that we're spending $85 million of full-time equivalents to administer $25 million of government assistance. And so, first of all, that seems crazy, but then I found out if we were to change the ratio somehow, where we had 1 employee per 10 recipients, that would free up an additional $32,000 per recipient. And I just have a hard time thinking if the welfare worker was able to spend 1 month out of the year with every recipient, that they couldn't figure out a way to get them, into a better situation. So are those numbers accurate? Is that really what's going on? And isn't that one of the biggest things? I mean, Tennessee has 14 per employee. So what's going on there?
You have 3.5 minutes.
Oh, God. So those numbers are accurate. We didn't factor them into how we ranked each state. It was kind of just there for informatory purposes. I think it goes back to the service integration aspect that I talked about, where if you have, so those are only DHS caseworkers, which means that's a DHS caseworker that's helping someone get off the TANF program, and then you have your transportation department that's helping someone with transport. Then you have, if Medicaid or food stamps aren't in the same department. So I think when you're integrating all of those services under one department, you're effectively getting rid of the fact that, I cover 13 states, and then you have a DHS worker that has 10 cases. So I think that, I don't know if that really answers your question, but you did a lot of math really quickly.
Shouldn't we fire a bunch of these people, is what I'm saying?
I think you have to look at your system by a case-by-case basis.
Yeah.
Is kind of we can look into it though.
Yeah, we can look into
Okay. With that, 3 minutes ahead of schedule. First, give a round of applause for our healthcare panel.
Thank you.
Really appreciate it. Thank you all for joining us and staying in. Nathan's holding up the survey, which means if you do have a survey and you would like to fill it out, please give it to Nathan or anyone else. I also want to thank my team, Nathan Makla, Logan Pike, and the man on the camera, Matthew Glantz, for all their hard work. We couldn't do this without that. Also wanted to mention, if you're requesting reimbursement, I'm not going to be in the office this week, but I'll try to get email out to everyone who's attended in the next couple days, and we'll get it to you as quickly as possible. I'm trying to think if there's anything else. 3 minutes ahead. I think that's it, but thanks again for attending, and let us know how we did. Thanks, guys.
Great job.